So now we have Dr. Robert Stevens, who is going to talk to us about big data analytics and the future of neurocritical care in 2062. Dr. Stevens.
Good morning, everybody. It's great to see a lot of friends and colleagues, both current and from the past. I like to think of, I'm not sure how this works, but. I like to think of the NCCU as a big tree, many branches extending out across the country as well as across the world, into the past, into the future. I also just want to quickly acknowledge Dan Hanley, who spoke just now, who is remarkable not just for his work as it's the top one, as a clinical trialist, but also as an educator, mentor, clinician, really a luminary in this field, a giant. So I'm very humbled to speak after Dan. Thank you. So we're going to talk about big data and predictive analytics. And we're going to talk about this maybe by casting a look towards the future, but also thinking about some of the work that's already been accomplished. And I just want to acknowledge the research support, both from NIH, as well as intramural support here at Johns Hopkins and from the European Union. So when we think about a neurocritical care unit today, I guess in the collective imagination, we conceive of a very busy space with a lot of people running around, nurses, doctors, monitors, patients in terrible condition, a lot of noise, a lot of discussion. And this is something which I guess is part of our daily lives. This is how we practice today in this data-rich environment, constantly absorbing new data, trying to make sense out of it, trying to take the best or make the best possible decisions. But I'd like to argue that maybe in the future, 40 years from now, the NCCU might look like this. So what is this empty box? What it means is perhaps that we'll get so good at doing medicine that we won't need NCCUs anymore, right? And what specifically do we mean? We mean that perhaps, with advances in biology and predictive analytics, we'll be able to detect early on all those folks who wind up in the ICU, detect their conditions, predict them, prevent them from getting worse, and maybe prevent them from having to come to the ICU at all. Perhaps as well, through advances in basic science, we'll be able to mitigate injury and accelerate recovery from these acute conditions that we see, these terrible conditions that we see in the ICU. Perhaps also through technological advances and predictive analytics, we can leverage devices, different kinds of wearable monitors that we can place on people so they don't need to come to the ICU to be monitored. We can monitor them remotely when they're on the wards or even at home or elsewhere. And so I'd like to argue that maybe intensive care medicine and neurocritical care specifically will become a different place, a smaller place, where we will still be taking care of very complicated, very sick patients, but a very different kind, the ones that sort of escaped our capacity for prediction and for treatment. And how would we achieve this? I think there's many different strands of discovery and technology and engineering that are going to contribute to the intensive care of the future. Certainly, we're going to be wanting to leverage systems biology, the use of high throughput techniques, for example, to look at the genome, transcriptome, proteome. We're going to be using a lot of artificial intelligence, and I'll talk a tiny bit about that today. We're going to be doing computational modeling. We'll be building these weird things called digital twins, which I'll talk about briefly. I think we'll be working a lot with brain-computer interfaces, right? Building bridges between our own bodies, our brains, and computers, algorithms that can help us potentially to function, to recover, to communicate. I think we'll be also using much more regenerative techniques. For example, restoring brain tissue and function in people with acute brain injury. So when we talk about artificial intelligence, we're really referencing non-biological systems that reproduce aspects of human behavior or thinking, right? So I guess the AI of today is largely based on learning, right? Machine learning. We have sophisticated systems that can ingest large quantities of data and learn. They can help us to predict and classify. We'll talk about that today. They have extraordinary memories. But what about some of the functions of the brain, of the minds that are a little bit more advanced? Things like abstraction, generating science, knowledge. What about consciousness? What about metacognition, meaning thinking, our capacity to reflect on our capacity to reflect, right? So these higher order functions, I think, are still a long way away from the reach of artificial intelligence, and we've got some work to do. This is just one example of a paper that was published last year from a group in Montreal and Paris. And the goal was to build an artificial intelligence algorithm, a deep learning algorithm, to reproduce aspects of not just cognition, but human consciousness, right? And I think it's a long way from that, but nevertheless, in the testing, within the constraints of the model that they built, they feel that they have an artificial form of consciousness, right? So from artificial intelligence to artificial consciousness. And you just imagine the implications if this research is able to go further. You know, will it be possible at some time in the future to upload our minds, our brains, onto another support, so that even when our bodies are no longer here, our minds will still be here. So again, this is about the future. What are digital twins? It's very simple. The idea is to simulate systems using computational modelings, right? So we can extract huge amounts of data from patients, from genomics to imaging to physiology. And we can build sophisticated mathematical models. And using AI, we can test all sorts of hypotheses regarding treatments, hypotheses regarding prognosis. And this is something which is really borrowed from the engineering world, and it's already taking place, right? So this is an example of a digital twin used to simulate epilepsy, right? So given certain imaging and EEG data, you feed that into the model, and you build a computational system that resembles the patient, where you can test what would happen if we resect the anterior temporal pole, what would happen if we give drug X or drug Y. And this is a very, very fascinating concept, the digital twin, because it's likely going to allow us to make significant advances in a much more accelerated fashion than the traditional clinical trial design that we are so enamored with. And what about regenerative medicine? So this is really one of the most exciting areas, right? We now know that you can take a stem cell, or even you can take a somatic cell from the body, and you can, using transcription factors, you can induce a pluripotent state. And then you can use that as the seed for an organ that you grow in vitro. So this is the so-called organoid. Organoids have evolved significantly over the past 10 years. We now have brain organoids. And not only do we have cerebral organoids, these are like these small three-dimensional tissues that we can grow from stem cells in vitro, but we can also integrate them into a living system, and then we can observe the establishment not just of synaptic contacts, but the integration of these organoids into functioning systems, right? So there's already several groups working on using organoids, cerebral organoids, to replace tissue lost, for example, in the setting of ischemic stroke or traumatic brain injury. So this is the pie in the sky stuff, which I think is already happening, and it's going to evolve very rapidly. But if we look at where we are now, we all, I don't have to remind this audience that acute brain injuries are one of the leading causes of death, many, many deaths every single day, leading causes of disability, according to the World Health Organization. Stroke is the number 2 cause of disability across the world. And the question is, what can we do to treat these people, right? So in the case of stroke, we all know that, image-guided reperfusion therapy works, right? So we know that we can give thrombolytics, we can do mechanical thrombectomies, fix the plumbing, and it's extremely effective. But if we look across the range of other acute brain injuries, traumatic brain injury, intracerebral hemorrhage, aneurysmal subarachnoid hemorrhage, if we look at clinical trials, in particular of neuroprotective agents or physiologic strategies like targeted temperature management, they're largely ineffective, right? Let's take the case of decompressive craniectomy for traumatic brain injury. How many patients do we have to treat to prevent a single death? 16, right? This is the number needed to treat. You remember it's the reciprocal of the absolute risk reduction between two treatment groups. 16 patients have to be treated to achieve one person that's saved. What about progesterone? Number of trials, earlier in this century demonstrating that it's not effective. 50 patients would have to receive progesterone for a single one to be saved. What about targeted temperature management after cardiac arrest? And I hope that Romer is not here listening, but 22, right? So you need to treat 22 people with TTM for a single one to survive with a favorable neurological outcome at 3 months. Even mechanical thrombectomy, 5, right? So only 1 out of 5 patients who receive mechanical thrombectomy are able to achieve functional independence at 90 days, right? So we're still a long way away from precision medicine, right? And this is, we think, due to something called heterogeneity of treatment effects, right? So when you treat a population, the effect is not going to be uniform. It's going to be a distribution. Some people are going to be helped by the treatment. Some people are going to be harmed. Others are not going to see any benefit. And heterogeneity of treatment effect is really just one manifestation of biological heterogeneity, which affects all of our patients across medicine, but in particular, it's very obvious in intensive care medicine. So the question is, what do we do, right? And I'm going to make the case that precision medicine could be a very compelling solution. So what is precision medicine? It's really, we're talking about leveraging data, right? So high-dimensional data sets that are available to us, together with strong mechanistic hypotheses, together with advanced modeling techniques, statistical modeling, and in particular, AI, in order to make more precise predictions, to classify patients more accurately, and make better decisions and achieve better outcomes, right? And so this was the idea behind the creation of the Johns Hopkins Precision Medicine Center of Excellence. So these are the faces of people that you recognize, a highly interdisciplinary group of very keen and motivated individuals who want to advance this vision of precision medicine at Johns Hopkins. So we have physicians, we have engineers, we have data scientists, we have nurses, we have neurosurgeons, we have anesthesiologists, we have neurologists, we have all sorts of people in this precision medicine center. And we meet on a regular basis, and anybody here who's interested should feel free to talk to Jose or myself, because we want more people to join this group. The basic idea is what I mentioned before. We leverage data, right? So imaging, for example, MRIs, physiologic time series data, clinical data. We hope in the future genomics. And we use computational models to make more individualized decisions about prediction, diagnosis, detection, prognostication, and perhaps most importantly, treatment selection. So in order to get, to achieve this lofty vision, there's maybe some first principles that we have to consider. One of them is that in order to decode the brain, we need to understand its structure, its function. In order to find more precise treatments, we need to understand the mechanisms, right? So to do that, we need to build a connectome of the brain. We need to understand how the brain is wired. We need to learn from both biology and physiology. We need to learn from phenotypes. And in order to do this, to achieve this vision, we need computational models. And this is represented here. And I'm just going to go through quickly some of the use cases, some of the research that we've done in my group, for example, to evaluate these different domains, all of them anchored again in biological mechanisms. So if we start with the connectome, We can characterize the connectome quite well using MRI. In particular, I see Dr. Hanawi is over here. If we consider the structural wiring of the white matter in the brain, we can characterize it, we can quantify it using techniques like diffusion tensor imaging. We look at the functional activation, we can use techniques like resting state physiology to characterize it. If we look at even CT scan, we can characterize parts or activities and changes in structure in the brain. So these are very powerful techniques. I'm just going to go through quickly some studies that we did over the past 10 years. This was a study using diffusion tensor imaging of the brain in patients with severe traumatic brain injury. We used that data to train a machine learning classifier, support vector machine, to predict the probability of functional recovery at 1 year. And we found that when we compared our model, our diffusion tensor imaging model, to a simple clinical model, it achieved much better discrimination. So this is the AUROC that Dr. Hanley was talking about. The AUROC went from 60 to 90, right? So doubled, almost doubled. And this was very encouraging. And building on this, we did similar studies. This is a study that we did in patients with anoxic ischemic encephalopathy after cardiac arrest. Again, we trained a support vector machine to predict the probability of recovery. And we found that the DTI-based score was much better than anything else in terms of predicting recovery. And this was integrated into a much larger study conducted by some of my colleagues in Paris, where using, again, the whole brain fractional anisotropy, this is this DTI metric that many of you know about, you can actually compute the likelihood of recovery with a discrimination of 98%. This is some recent work, more recent work, using DTI still, but this time in patients with aneurysmal subarachnoid hemorrhage. This is Dr. Nelson and Casey Weiner, who's a BME, biomedical engineering PhD student working with us. Using diffusion tensor imaging data in patients after aneurysmal subarachnoid hemorrhage, we were able to build a connectome, and we analyzed the connectome and how it related to recovery after the ictus. And we did find that actually there was a strong relationship between the connectional architecture of specific nodes in the brain and the likelihood of achieving a favorable modified Rankin scale at 3 months and 6 months. And that the connectome-based score was better at predicting outcome than the sort of traditional WFNS or Hunt and Hess, which are currently in use in the clinical setting. And what about functional MRI? So this is a study that we did with Dr. Hanawi. We were interested to understand how the changes in functional connectivity in patients after cardiac arrest might be predictive of 1 year outcome. We characterized specific canonical networks in the brain, for example, the attention network, the default mode network, the salience network, the executive control network. We found indeed a relationship between diminished connectivity and worse outcomes. And even more interesting, we found that an anti-correlation that existed between networks, no longer within networks, but between networks, was actually the loss of that anti-correlation was the strongest predictor of outcome in this cardiac arrest population. Suggesting again that this connectional architecture is hugely important in terms of mediating function, but also recovery. Dr. Hanawi and I also worked together on this paper that came out a couple of years ago. This time we said, well, this is all well and good, DTI, resting state functional MRI. These are techniques and modeling strategies that are not widely available. What about if we just take a very simple study, CAT scan, right? Is there any information that we're missing in the CAT scan? Can we use quantitative methodologies to better characterize the CAT scan? And so this is the object of this study. And what we were able to do is, using a computational method, we were able to segment, anatomically parcellate the brain using an MRI template. And we broke the brain down on CT scan into these anatomical segments, and then we measured the density, the radiological densities in these different areas. And indeed, we found, as others have found, a reduction in radiological density in those anatomical areas that were most linked to the brain networks that we had studied before using resting fMRI. So there was a reduction in patients who did poorly in those areas. And we reconstructed brain networks from the fMRI data in the CT scan. And we found that breakdown of those networks, at least in terms of radiological density, was associated with significantly worse outcomes. And that models using this data actually predicted outcome quite well. So if we talk about physiology, just wanted to highlight this abstract from Dr. Mather from Rohan, which recently was accepted to be presented at the Neurocritical Care Society annual meeting later this year, and actually won the Best Scientific Abstract Award. So congratulations, Rohan. And so what Rohan is doing is he's applying computational methods, machine learning, to understand how specific waveform changes of the ICP time series can be used for the purposes of classification and prediction. And so he's using an unsupervised learning technique. You know, broadly speaking, you can think of artificial intelligence as having the supervised techniques where we kind of provide annotations and instructions to the algorithm about how to train, and unsupervised where essentially the algorithm is free to detect patterns on its own. And so Rohan's going to be presenting this exciting data at the NCS meeting later this year. I just wanted to highlight also another faculty in the NCCU and member of the Precision Medicine Center of Excellence, Dr. Rosenblatt. This is Kate. And Kate has been very interested in cerebral autoregulation and changes in cerebral autoregulation as they might occur, not just in acute brain injury, but in patients with conditions like septic shock, right? And she's now increasingly using computational methods to better analyze the changes in the autoregulatory indices in different patient populations. So these are two recent abstracts that she presented, very exciting work. My group has been interested in leveraging data from the electronic health records and also from the physiological time series. This is a recent paper where we predicted the onset of delirium in the ICU. Two different models, a static model and a dynamic model. And we were able to predict delirium with high accuracy. So using physiologic data from the first 24 hours, we had a discrimination of around 75%. So that was quite impressive, better than the existing standard. And we were able to, this model was not just a black box, we were able to understand the specific features that were most strongly associated with the onset of delirium in the ICU. So this is outside of the neurocritical care unit. This is a paper that was done together with colleagues from biomedical engineering, where the goal was to predict the onset, or I guess the outcomes of patients after cardiac arrest. And here again, we used physiological time series as well as clinical data in a machine learning model. This was a supervised machine learning model. And we had actually excellent discrimination here again. The model that used physiology combined with clinical data was much more powerful than the model that used either alone. So physiological time series certainly contains information that is important. And remember that this is data that is widely available in all ICUs, and we only use the data from the first 24 hours. So just basically by extracting data from the first 24 hours, you can build a reasonably discriminative model that tells you whether a patient is going to die or achieve favorable neurological outcome. This was a very similar study that we did for patients with traumatic brain injury, also working with a team from biomedical engineering. And this shows you essentially the sort of modeling pipeline that we developed. The goal was to predict neurological function and mortality in patients with TBI admitted to the ICU. And here again, the discrimination of our model was good. It was better than existing widely published models, for example, the impact or the crash model. So we were quite excited by these results, and now we're building on this in a much larger data set called center TBI. The problem with TBI, with traumatic brain injury, is that prognostication is hard. So this here, I'm showing you the data from the best available models, center TBI, European multi-center study, 5,800 patients, and track TBI, American study, 3,800 patients. And using all the available data in these essentially precision medicine studies, the best discrimination we get is about 85%. The reason is because TBI is such a complex disorder, right? People have said that maybe TBI is the most complex disease of the most complex organ in the body. The recovery that occurs after TBI really depends on so many things, right? The pre-existing factors, the magnitude and distribution of lesions in the brain, the capacity for recovery and regeneration, which is largely dependent on age, some plasticity, as well as the tendency of patients to undergo neurodegenerative processes after traumatic injury. It's a very complicated story, right? And the thought that we had is maybe we can break down this hugely complex population, these heterogeneous TBI populations, into smaller units that are more tractable, right? So perhaps we can leverage data. For example, all these different omes that we've talked about, genome, epigenome, metabolome, immunome. We can extract the data, and using unsupervised modeling, we can identify subgroups or subphenotypes that'll provide us with insights on disease and perhaps guide therapy. So this is some work that's ongoing in my group. We have the data from Center TBI. We're breaking it down into clinical, physiologic, imaging, and biomarker data. And we're performing unsupervised hierarchical clustering analysis. This early data, this is not published, we found 4 distinct clusters, each associated with specific likelihoods of mortality and favorable, unfavorable neurological function. This is a heat map illustrating, so the rows illustrate specific physiological variables, and the columns are individual patients. And you can see it's broken down into A, B, C, and D. These are the 4 different clusters or subphenotypes that we were able to identify just using physiological data. And the goal is going to be to use these subclasses. First of all, we need to validate them, both clinically, biologically, but perhaps these subgroups, if they're more homogeneous biologically, would be more responsive to specific interventions than these undifferentiated larger populations. So lastly, I just want to talk a little bit about phenotypes. My group has been very active in this space. The idea is that if we study the external phenotype of patients, maybe we can learn something about their internal physiological condition and their neurological state. So we've been focusing on motor function, vocal features, and facial expression. This is a paper that we published a year ago. I'm showing you photographs of some of the co-investigators from electrical and computer engineering, as well as invaluable help from people from the Precision Medicine Center of Excellence, Eusebia Calvillo, as well as Peter Jejic. So essentially what we did is we placed accelerometers on the arms and legs of patients admitted to the NCCU. And we measured continuously at high frequency the movement of the extremities in these comatose NCCU patients. And then we did quite a lot of feature engineering. So we extracted these time series of movement, and we ran them through different feature engineering techniques, time domain, frequency domain, fast Fourier, in order to better predict fluctuations in the level of consciousness. That was one thing, and perhaps also outcome. We found that it was okay at predicting outcome, but it was quite remarkable at predicting transitions in the Glasgow Coma Scale, right? And so simply by monitoring motion time series, we're able actually to detect if a patient's GCS is going to go up or down. And we're able to do that actually several hours before it's clinically recognized. So this is very interesting information. It's early, it's preliminary, but we were encouraged by this. And based on this motion sensor, this accelerometer-based sensing system, we're now building a new sensor array that not only measures motion, but also an array of other physiological variables. So things like pulse oximetry, heart rate, respirations, blood pressure, EMG, actigraphy. So this is a sensor prototype that was created by John Rattray, who's an ECE PhD student that is working with me. And we just received approval from the IRB, and we're going to be implementing this study shortly in intensive care unit. This is a readout from this particular device. You can see that it's placed on the finger. We're recording ECG just from a single finger probe. We can record ECG, we can record pulse oximeter, we can record respirations, right? So this is where things are going, I think, in terms of monitoring. We're going to see more and more of these very parsimonious, smaller and smaller sensors that give us a huge amount of physiological data, not only in the ICU, which is a great testing ground, but also in the general population. Just very briefly want to mention a study which is ongoing. This is a study where we're filming the facial expression of patients who are admitted to the hospital for stroke, right? So these individuals come to the hospital, there's a BAT, a brain attack team it's called. The team converges, decisions are made, reperfusion, no reperfusion. And then a few hours later, once the decisions have been made, we film these patients using a smartphone. We wanted deliberately to use a device that is widely available. So we're filming them using an iPhone. And the basic idea of this study is that the face is a very dense signaling instrument or mechanism, right? So the face contains a huge amount of data. When we look at somebody that we know, that we don't know, the first place that we look is their face. We're constantly scanning their face for clues, for signs, not just on what they're thinking and feeling, but also are they physiologically okay, right? Have you noticed that you can walk in, most clinicians, after a few years of experience, can walk into the room of a patient, immediately get a sense this patient doesn't look right. But the question is, what are you actually seeing? If I ask you, what do you mean doesn't look right? You're going to say, I don't know, it just doesn't look right, right? But you're actually capturing something very complicated. And the question is, can we decode that? So that's what we're doing in this study. We're analyzing facial expression, but we're also analyzing microfluctuations in facial color. And we're able to extract from that a huge amount of data on underlying disease conditions, such as stroke in this case. We've already enrolled 160 patients. We're analyzing the data. But we can also impute or compute things like PPG, basis of the pulse oximeter, blood pressure, heart rate, respiratory rate. So you get from a single 20-second image or film of the patient's face, you can potentially get diagnostic biomarkers, and you can also get a physiological assessment. We did a similar study, this time no longer looking at the facial expression and color, but also looking at the characteristics of the voice. Have you noticed? You get on the phone with somebody that you know very well, your mother, right? And you can tell within a couple of seconds, maybe a fraction of a second, if something is not quite right. But then if I ask you, what did you detect there in your mom's voice? Your answer is likely going to be something like, I don't know, she doesn't sound right. So can we decode that again? And the answer is yes. We know that the voice contains physiological information. It tells us about not just how somebody's capacity to communicate, but also about somebody's underlying physiological status and disease. So we use this here. We enrolled 80 patients undergoing major surgery. These were older patients. And the hypothesis of our study was that vocal features preoperatively would be predictive of postoperative cognitive impairment, in particular delirium. So unfortunately, in this particular data set, the incidence of delirium was very low, so we're focusing now on other endpoints. But the analysis is ongoing, and we're very excited. So I just want to conclude by a few takeaways. I think we all know in this room that acute brain injuries are leading causes of death and disability, and that we don't have effective therapies, right, largely speaking. We can fix the plumbing for patients with stroke, but beyond that, really? A major challenge, of course, is to develop effective care. And the way to do that, I think, is to solve this issue of biologic heterogeneity. Resolving such challenges requires a principled approach, first principles, in which we use mechanistic knowledge, technological innovation, and advanced modeling, including AI, of course. And certainly, I think the neurocritical care space, which is an early destination for so many of these patients with critical brain injuries, is a unique window to test such a paradigm. I just want to recognize many, many investigators here at Johns Hopkins, as well as not just in the School of Medicine, but in the School of Engineering, of course, School of Public Health, Applied Physics Lab. Many colleagues and investigators in other centers in the US and across the world. And also a number of students that have been working with me over the past few years in the Laboratory of Computational Intensive Care. This is a recent dinner that we had with a bunch of students, many of them graduating with masters or PhDs after doing this work. And I think I'll stop there, but thank you very much.